and we all know why we're here, is to promote the good work that Nous is actually doing in order to actually highlight the issues, what's happening within the mental health system in the provision of its services to Black and Asian minority service users. Today, we have a few speakers from various backgrounds within mental health who are going to give us a talk on their experiences on their service provision. And also, we have Councillor Ahmed with us today, the Mayor, who's going to give us an initial introduction. Also, we have Dr. Shade Olbaja, she's based from Kent. And, sorry, corrected. Sorry, eligible, apologies. And we have Dr. Maimuna Kadiri from Lagos, Nigeria. So without further ado,
thank you all so much for coming. Because most weekdays I've got 2 hours commute from work and 2 hours back. So it's like Saturday when I just want to lie down. But when you have a cause and when you have a passion that you're very, very, very concerned about, your passion will drive you and it will get you up to do what you know is right to be done. And that was why about last year, February, we started the Nous organization. The Nous organization was started mainly because there had been a burning desire in my heart. I work in the social care sector. I've also worked in the front line as well. And frontline has been a support worker, and I noticed a disproportionate number of Blacks, Asian, and minority ethnics in the mental health sector. Obviously, when you sit down and look at the reasons why, you know straight away that within those various communities, there's a higher there's a higher level of stigma, there's a higher level of very negative stereotyping with people who have mental illness. So you find that a lot of Black, is it okay for me to just use the word BAMI? Instead of saying Black, Asian, minority, ethnic community. So a lot of the BAMI communities don't actually approach the mental health sectors on time. So by the time they go, you know, the illness, whatever it is, whether it is depression, it has become chronic depression, clinical depression. If it is bipolar, it's gone really high, and there's just lots of issues in the communities. And I just felt last year that, listen, this is something we need to do. Let's take this message to the grassroots. We go into the communities. We talk about, we break the words down in languages that the community can understand. So for example, somebody says bipolar. What is bipolar? To the average man on the street, it sounds very, very far off. Somebody says schizophrenia. You get scared, it's like, oh. Especially when you look at all the media and something goes wrong, and the next headline you see in the newspaper is schizo man kills, schizo man does. And then words like psycho, there are lots of negative words that are used to describe people who suffer mental illness. And for me, the passion just burned, and it was like, listen, you need to go out into the community and break this message down so that people would understand. So we hold workshops, we hold seminars, we'll go to community events, we go to churches, we go to mosques, we go to anywhere, just for us to spread the news. So for people to be able to understand that there's nothing wrong with mental illness. Of course, there's something wrong with it, but it's just a fact that mental illness is like physical illness and should not be discriminated against. So if we're promoting research around cancer, if we're promoting research around finding a cure for other illnesses, dyspraxia, other types of illnesses, why aren't we promoting a research to help with mental illness? A lot of this is because people have kind of pushed things to the back. Last year when I started the Nous, it was based on, apart from the fact that I noticed that there's a disparity in our community, it was also based on the fact that the previous year I'd been unfortunately privy to 4 people who died by suicide. That's the leader of the house. I'm going to introduce everybody later, Councillor Mohammed Bott. The previous year, I had been privy to 4 people who died by suicide. I don't want to use the word committed suicide. And one young one was actually because his mom told him that he failed. He actually had a C in maths, and he was intending to go and study medicine in uni. Because he had a C, the mother went all out. It was a Thursday evening. Oh, you had a C, that means you can't study medicine any longer. This is going to happen to you, that is going to happen to you. And this young boy, the mother not knowing that he had been depressed, this young boy goes upstairs. The mother tells him, can you run the bath for me upstairs? He goes upstairs. 15 minutes, 20 minutes, 30 minutes, the mother was downstairs counting. And then suddenly it dawned on her, she called his name, there was no answer. So about 40 minutes she went upstairs and she finds the hung body of her son in the room. Another one happened, this was early last year, that was before I started the news. A very young, fine woman, nothing wrong, fantastic marriage, you know, the way we describe it. Good job, no financial problem. On a Sunday, they come back from church. She said she was going to go out for a walk. She goes out for a walk, and about 30 minutes after, the family hears siren blaring, thinking, okay, maybe something has happened on the road, let's just wait. 30 minutes after, they hear a knock on the door. This woman had jumped over a bridge. Nobody noticed. Last year, I was actually at an event, and I got a very panicky call from someone because I advocate for people who have mental health issues as well. So last year, I got a call from someone. One of my members has been sectioned. She's in the hospital. And the question that went to my mind straight away is that, okay, you are in this community. How come no one noticed that this woman was going downhill? Did anybody notice when she started dressing in a different way? Did anybody notice when she withdrew from the crowd? Did anybody notice when something just went wrong? And you know, all of these events coming together just made me realize that we do need to talk about mental health issues in our community. This is a passion, and I'm happy that you're all here today. Thank you very much. I'd like to recognize the presence of the Lord Mayor. Thank you so much for being here. Also the leader of the House, Councillor Bort, Mohammed Bort, thank you for being here. Councillor Sandra Sabir, thank you very much. Councillor Hirani, thank you very much for being here. And they're here mainly to hear us. They're here to hear us. And I'm hoping that we would all talk later because we call it how do they drop the signs? These are things that we're going to talk about. And I'm hoping we'll all be able to take one thing or the other away from here, so that when we go back to our various communities and our various families and enclaves, we can use whatever knowledge we get from here. Thank you.
I'm sure you'd all agree that was a very passionate speech by Lade. Yes? Yes. Okay, I'd like to introduce the Mayor of Brent, Councillor Partners Ahmed, to give us 5 minutes of his time.
Good morning to all of you.
Good morning.
First of all, I'd like to say welcome you all today at the Brent Civic Center. It's a great event we are holding today. I was being everywhere in the Brent when I have found it out some difficulties organization delivering some good services, which is I have chosen finally 3 organizations which is they are doing very good job for the local community, which is in Brent. So my 3 charity, one is which is related with the mental health for the young people. Organization called Brent Center for Young People, they are doing work in the schools. So I think Nous is doing the same thing for the adult and children, I believe, as well. So you people doing a great job. We have a lot of speakers in here today. It will be hard from all of you, what sort of problem we are facing right now and what we can do in the near future as well. Yes, mental health problem is not in the locally, it's nationally, it's a big problem right now going on, and especially in BME sector. We can do a lot more what we are doing right now. We need to give more awareness as well. If anyone of the family is affected like this illness, then whole family is affected actually. So obviously as a Brent Council, we have a lot of councillors in here, leaders in here. We are working on, especially Krupesh in here, he will say a lot about mental health. And my humble request to all of you as well, that please we do care about, we should need to think positively how we can help about this problem, how we can solve in our locally in Brent especially. If we can go for the further age other than Brent. But we need to think about the Brent. We have a lot of problem. I have found it out in my visiting last 2-3 months time, which is I've been many part of the Brent. And many people are also suffering this sort of problem. So only I can say to you, let's see what we can go for, whatever couple of hours time we will discuss about it. And from myself, definitely I'll be with all of you. If you need any help from my side, my presence sometime in future as well, I'm available. That's only I can say to you all. And my also apology will be I'll be leaving about 11:40. I have another engagement at 12 o'clock. So before that I'll be in Canfield. Thank you very much to all of you.
Apologies, I promised this isn't my normal look. I was out last night. I had a surgery for a former nose which broke my arm playing football. So I'm here and we talk about getting up early in the morning on a Saturday, but this time yesterday, I was knocked out on anaesthetic, which was yesterday. So, but I made sure I got here today, quick recovery, but I won't stay for long. But Lado talked about how we should look at mental health more seriously. And one of the things that I'm passionate about, and that we're pushing in Friends, is this vision of whole person care. That's looking at the person's needs, physical, social, and mental. And that's what we're looking to implement in Friends. I chair the Husband Wellbeing Board, so we've got a strong need of getting all our partners around the table, such as the NHS, so that they look at things in the same way that we want to champion, so that we can look at issues and tackle them together. So we have looked at how we can help support people who have mental ill health, and look at how we can actually have social workers and housing staff working. Sometimes it's bad, and it's something that affects everyone, no matter what. At the moment, my mental health is probably good, but my physical health isn't so good. So it affects people in different ways. And one of the things I'm glad about today is also that you're bringing these issues about depression and suicide into the forefront as well. Because these things are not talked about so much. And I think especially in the BAME community, you find that sometimes it's things that are trivial that can even drive people to suicide, not being accepted by your own community, which is really difficult to have. Who's raised that awareness amongst decision makers about suicide as well, and I know that Lada's trying to address that through this. I used to work for a disability charity, and it was around the time when there were lots of changes to disability benefits, and we had quite a number of cases all across the country where people had tried to attempt to take their own life. And it was really tragic at that time because what we found, I work with people with spinal cord injuries, so these are people who were active and had no concept of disability before their injuries, but a road traffic accident or a fall or a traumatic incident can mean that their lives change for the rest of their lives by one incident. And working with people there, I saw that actually this series of events that can turn someone's life around in the wrong way can happen to anyone. It can happen to me, it can happen to you, and we should have those support mechanisms. One case I can remember dealing with where we had to get the MP involved because someone hadn't had their disability benefits. They were waiting for an assessment for 12 months, which means they had no money. They had no means of actually paying their rent. They had no means of paying their bills, and we had to get this person's MP involved. And I think the MP, when we told about the story, was in tears. And just that meant that it had a change in how that person approached, how that person looked at making decisions when they were looking at things like disability benefit cuts. So thank you, Lada, for setting this up. And I hope to support your organisation. It's really amazing to see people here on Saturday morning to help get that message out as well and learn more about depression and suicide and how mental health affects the BAME community. And I'm grateful for you to set it up. Thank you, Laura.
Thank you.
Thank you, Councillor Irani. Our next speaker is Dr. Shade Olajibu, forensic consultant psychiatrist.
Mayor, councillors, distinguished ladies and gentlemen. It's a privilege, it's an honour, but it's also very humbling to be standing before all of you this morning. And let me start by saying thank you to Lade and the Nous for the privilege of standing here. Like Lade, I'm very passionate about mental health, about mental well-being. And it's due to my experiences, actually, that took me into mental health. So, you know, BT says it's good to talk. And I feel that it's very important that we talk about this. And I start off by making a disclosure. You might say that I'm qualified to stand here because I'm a psychiatrist. You might think I'm qualified to stand here because I'm a therapist, or I teach doctors in psychiatry. But I think the greatest qualification I have is that I'm a survivor of depression. And it was my struggles with depression that took me into mental health. And it was my struggles with depression that motivated me to try and take myself as far as I could go in the world of mental health, so that not only could I understand my own difficulties, but through my own learning and my own understanding, I could help other people. So the basis of me being here today is as a survivor. And my 20 minutes talk or so is really about educating people about depression, about suicide, which is strongly associated with depression, but also about how we individually and collectively can identify when people are suicidal. So that's the remit of my talk. So can I get some help with that? Yeah. Will somebody be able to, would you be able to just help me forward? Yeah. So next one. No. Yeah. Back to the first one. Just go really slowly. Back. Thank you. Yeah. So I start off by saying, or making a statement as set up by the World Health Organization. The World Health Organization takes suicide, takes mental illness very seriously. And in fact, they have a strategy known as prevention of suicide, and they say it is a global imperative. What does it mean? They're basically saying that mental illness and suicide is a worldwide issue that needs to be addressed globally. And this is what they say: raising community awareness and breaking down the taboo is important for countries to make progress in preventing suicide. And when you see the statistics, you'll understand why. Next. So I'm going to talk a little bit just about what mental illness is and what depression is, so that we're all singing from the same hymn sheet. And like Nadia, I'm hoping that you will learn something, or it will refresh your memory if you already know these things. And I apologize to those who, you know, haven't experienced of mental illness, and for them this is just really basic. So mental illness is basically an illness of the mind, in the same way that physical illness affects the body. And mental illness, by its very nature, affects your thinking, that's cognition. And in affecting your thinking, it affects your emotions. And because it affects your thinking and emotions, it then goes on to affect behavior. Next slide, please. In terms of mental illness, there are two major categories of mental illness. You have organic mental illness, where you can identify a disease of the brain or a disease of the body, which then goes on and affects brain function and leads to mental illness. And you have what we call functional mental illness, where you can't really identify anything physically which is causing the mental illness. It's really important. I know that many of you would have heard this many times before, but it really is true that 1 in 4 of us at some point in our life are going to experience a mental illness. And I think it's important to say right at the beginning, even though today the remit is about depression and suicide, that, you know, mental illness is like physical illness. If I have a cold, I'm physically unwell. And the cold is, you know, very mild respiratory symptoms. Pneumonia, which is also a respiratory illness, could be life-threatening. The same thing with mental illness. Sometimes you have a very mild mental illness, which may have limited impact on your ability to function, and sometimes you can have a severe mental illness which could predispose you to feeling suicidal or stop you from functioning completely. So what is depression? Again, I apologize if this is not new to you. Depression is a mental illness. And I'm very passionate because a lot of times in black and ethnic communities, we look at depression or mental illness as something very strange, and we don't have a proper understanding. But depression is primarily a mental illness. The World Health Organization says that, 350 million people worldwide are affected by depression. And if you break that down, it means that 1 in 20 individuals is a sufferer of depression. So you can see that it's, occurs quite frequently. The challenge with depression is it affects your functioning. Remembering I've said mental illness affects your thinking, your emotions, and your behavior. And mental illness affects all, those parameters. And from an economic perspective, it is the primary loss in terms of disability. So because of depression worldwide, many years are lost in terms of people not being able to function, not being able to work, because they're experiencing symptoms of depression. Next one, please. Now, what are the symptoms of depression? I start off by saying that depression is not feeling unhappy. Yeah? There is a difference between being unhappy and being clinically depressed. A lot of times, if I ask somebody, how are you, and the person says, I'm depressed, actually what they're saying is, I'm unhappy. Now, if something happens to me which is not very nice, I'm going to be unhappy. But I'm not necessarily clinically depressed. So I'm going to just take you through the symptoms of depression. For somebody to be diagnosed as depression from the point of view of the medic, this person must be suffering from low mood every day or for most days for at least 2 weeks. So it's not I woke up this morning and somebody upset me and I'm happy. The person has a chronically low mood for at least 2 weeks. For me as a clinician, as a doctor, when I sit with people who are suffering from depression, they typically say that they feel worse in the morning and they have great difficulty getting out of bed in the morning. And depending on how severe their depression is, it may be that there's a slight lifting of the mood as the day progresses, sometimes not. In addition to the low mood, there is a loss of interest in the things that would normally give them pleasure. So maybe, for example, I like music. But in times past, when I suffered from depression, music didn't give me pleasure. Nothing gave me pleasure. And the person loses an interest in the things that they would normally enjoy in terms of friends, family, etc. In addition, this person or person will have reduced energy levels. So you've got the low mood, the loss of interest, and low energy levels. And a lot of time, that will manifest in terms of the person's self-care becomes very poor. So I remember times of not being able to get out of bed in the morning and finding it really difficult to shower and take care of myself. In addition, not only does the person have low energy levels, but they get easily tired. So little things wear the person out, and it is not laziness. Very important when you have young adults or young people. It's not helpful saying pull yourself together. Trust me, I've been there. If you could just pull yourself together, you would. And it's also characterized by consistent sleep disturbance. So the characteristic of sleep in terms of a lot of depressed people talk about either having difficulty falling asleep or getting to sleep but waking up very early in the morning. The typical thing I see in patients is somebody saying, doctor, I got to sleep but I woke up at 4 o'clock in the morning and I just could not go back to sleep. The shift of that is that sometimes people with depression sleep too much. So they're just sleeping all through the day. And for me, I think I've suffered both historically, where I would just stay in bed all day trying to sleep, or I just couldn't sleep at all. There are appetite changes, and again, a lot of people with depression will stop eating or reduce their appetite and they'll lose weight. But some people will just continue to eat, a form of comfort. And then there's change in what we call psychomotor activity. So some people with depression are actually quite agitated, and some people with depression are very, very, very slowed down. One of the things that I said at the beginning was depression affects your thinking. So many people with clinical depression have problems with attention and concentration. They can't concentrate on anything, can't watch TV properly or read a book. They're very indecisive. Another thing which links into the suicide is they start having these feelings of guilt and self-reproach, and they lose their confidence, and there's a sense of very low self-esteem. Sometimes when people are clinically depressed as opposed to just unhappy, they have associated anxiety symptoms, so they're very anxious, and they may have what is called somatic symptoms. What do I say? For many people from the BAME community, it's very difficult to say I am depressed. and a lot of people from BAME communities, they will also experience physical symptoms. But these physical symptoms have no physical root. So I have patients who say when they're depressed, I've got a headache, I've got stomachache, etc. But when you know them, really it's a manifestation of their depression. I have to say, these symptoms are real. They just don't have a physical cause. Next slide, please. Now, this is a very important slide. If you don't take anything else away, a lot of people who are clinically depressed, in terms of their thinking, they will have what I call the triad of worthlessness, helplessness, and hopelessness. And it's these thoughts that then key into suicidal ideation. And they go on, and a lot of people, when people are severely depressed, start having recurrent thoughts of death, suicide, or engaging in suicidal behavior. Next slide, please. I want people to understand that, you know, whether somebody has a mental illness or not, suicide is driven by this. It's a sense of hopelessness, it's a cognitive trait, it's a thinking trait associated with suicide, leading suicidal patients or people who want to commit suicide to believe that suicide is the only feasible strategy for dealing with their insurmountable problems. Essentially, a person who resorts to suicide or is thinking strongly about suicide feels there's no other way out to whatever they're going through. And I have to say, of course, it's not everybody who commits suicide who has a mental illness, but all people who commit suicide feel that they have no other way out. Now, in terms of depression, just for people to think, Lade touched on it, there are different, depression can occur as an illness by itself, which is unipolar. It can occur in the mental illness known as bipolar, where a person suffers from both episodes of depression and episodes of being high in mood. Very common in women is postpartum depression, so women who have a baby and then go on to suffer from clinical depression. And depression can occur in conjunction with other mental illnesses. And in terms of, you know, categorizing depression, it can be mild, it can be moderate, and it can be severe. And whether from a clinical point of view you determine delineate as mild, moderate, or severe is dependent on the number of symptoms that I've described. Of course, if somebody has lost touch with reality in terms of psychosis, or they're suicidal, that automatically classifies that person as suffering from very severe depression. And this is really important to remember, that at its worst, suicide can lead, depression at its worst can precipitate suicide. Next one, please. So what is suicide? You know, it's important to say suicide is the act of deliberately killing oneself. So emphasis on the deliberate. It's not accidentally killing yourself. It is deliberate. The person's aim is to kill themselves when they undertake that act. So some of the facts that I again went to look at facts and figures over this week. WHO says that 800,000 people die due to suicide every year. That's why it's a global problem. And I think it's important to remember that for every person who, for want of a better word, completes suicide, there are many other people who attempt suicide. This is just because I work in the Mental Health Trust in Kent, I'm privy to some of the stats in terms of the prevention of suicide and homicide. And, you know, leaf Brent is quite high up there in terms of the rate of suicide. I think 7.2%, yeah. Next one. So this is a bit of learning for everybody. What are the risks associated with suicide? The first thing to say is that suicide will be associated with any chronic or debilitating condition, whether that's a physical health problem or a mental health problem. You find out in terms of mental health difficulties, such things such as depression, schizophrenia, alcohol and substance abuse are associated with an increased risk of suicide. And for physical illness, things such as cancer, HIV, neurological disorders which are debilitating, and chronic pain. Next one, please. Other risk factors for suicide are moments of crisis. So anything where the person interprets it as a crisis, financial problems, relationship breakdown, conflict situations, disaster, domestic abuse and violence, a sense of loss and a sense of isolation, can increase the risk of suicide. It's really important, this last bit about a sense of isolation. Like I spoke about the people who committed suicide, that lady, she was married, but clearly she must have felt really isolated. You can be surrounded by people, and I understand that, being surrounded by lots of people, but still feeling very isolated. And towards the end, I'm going to teach you how you can know if somebody is possibly at risk of suicide so that you can provide help. It's also important for us to know, in the BAME community, that this particular group, these groups of people are very, vulnerable to suicide, because of course they feel isolated for all sorts of reasons. So ethnic minorities, prisoners, refugees and migrants, and the LGBT. And they say, and I guess it is true, that the strongest risk factor for suicide is a previous suicide attempt. Next, I'm going to try and go a bit faster. So we've touched upon stigma and taboo. And as I said at the beginning, it's good to talk. You know, there is a lot of stigma around mental disorder. And it's forums like what we're doing today, which is going to help to remove the stigma and allow us to start talking about this very serious issue which affects all of us. So, going to national strategies. What are the strategies that collectively, so I'm speaking to our mayor, to our councillors, you know, you're here today. These are the things that the WHO recommends that we do in communities. And I say, speak to you directly, sirs and madam, because you are the people who can push these things forward, along with NGOs. So community psychoeducation, which is what the Nous is doing today. But also, in terms of strategies and policies which reduce the access to the means of suicide. We also need responsible media reporting. Sometimes our media are very irresponsible in the way in which they report suicide and mental illness. We need policies to reduce the harmful use of alcohol and drugs. We need to have early identification, treatment and care of people. So I'm speaking to the Commissioner over there in terms of, you know, mental health services that are fit for purpose, that are funded and resourced to do the work. And we need to make sure that there's adequate follow-up and support for people who are battling with depression and who have battled with suicide. Next one. So, a few stats going through very quickly. So that should say 2013. Between January 2011 and 2013, in England and Wales, that number of people committed suicide. That is a lot. 14,650 people who lost hope. And only 26% were in contact with mental health services. Why do I say that? It's because don't think it's just the business of we in mental health services to support people with mental illness and depression. If only 26 people, and these are official statistics that I had access to in the course of my job, that means about 74% of people who have committed suicide weren't in contact with mental health services. That's why it's everybody's business. This is my quote: don't be an ostrich. Ignorance is not bliss. Ignorance literally kills. So, this is me now talking. We all need to have a personal strategy for addressing suicide because, as I said, 74 to 75% of people who commit suicide were not in any way engaged with mental health services. That's why it's everybody's business. So I start. It is everybody's business. 2, nobody should go through the experience of depression or suicide by themselves. And whether it's you who's depressed and feeling suicidal, or you know somebody, there should be a low threshold for seeking help, either for yourself or for somebody else. Next one. So, are you struggling? Be prompt to seek support. I've stood up here as a mental health professional. I could easily not have told any of you that I suffer from depression, but I want to remove the stigma. People do get better. That's why I'm standing here. That's why I'm practicing. That's why I teach people about suicide. That's why I'm a training program director. I actually work with Health Education England, and I'm responsible for training psychiatrists in Kent, Surrey and Sussex. People do get better. Mental illness is not a life sentence in terms of you become mentally ill and you're not able to ever function again. I'm a living witness to that. It's my experience. You need to be proactive if you notice somebody suffering with suicide, or the signatures that I'm going to say very quickly, in terms of reaching out to people. For example, the example Lade gave, I'm sure that there were pointers that this woman was going to commit suicide, but the people around her didn't know or didn't recognize those pointers. And as I said, be prompt in seeking support, including, you know, therapy, counseling, etc., mental health service input. Next one. So this is the bit, again, that I want everybody to take away. If you can't remember all the other stuff apart from it's a global problem and it's everybody's business, this is how you will recognize if somebody's about to be suicidal. And it's an acronym. It's called It's Path 1. That's to help you remember the steps. Next one. So I stand for ideation, thinking. So a person who's on the verge of committing suicide will in some ways may have communicated it or threatened to commit suicide. S is for substance abuse. So somebody is using alcohol or psychoactive substance drugs in a very unhelpful way. P is purposeless. The person is somehow expressing or you're thinking that there is no purpose for living. A is somebody who's markedly anxious and agitated. T, the person feels trapped and they feel there is no way out. H is for hopelessness. W is withdrawal. The person becomes isolated from friends, family and associates. A, anger. The person may express uncontrolled anger. R is recklessness, engaging in risky behavior or impulsive behavior. And M is marked mood changes. They might be dramatic, marked extreme. So the person who's normally very bubbly, who then becomes very quiet, or the person who normally has a quiet disposition and suddenly becomes very loud. I say all of that basically also about just wrapping up is just talking about services. So in the Brent I went to do my homework and these are some of the places where somebody who's either suicidal can get help. So we've got the Brent Talking Therapies, the Big White Wall and the mental health services, and this can go out so that people have the contact numbers. And next, more services in Brent. Brent is quite well resourced. Next. And of course, in terms of the Royal College of Psychiatry is the body that registers medical doctors, and they have a wealth of leaflets and information that you can get on their website. And of course, the Nous, and of course the Nous organisation. Thank you very, very much for listening. I hope you
social care. So hopefully I mix a range of things together. Formerly I'm a social worker, I suppose, but I'm more qualified as a psychotherapist. I've spent 20 years as a Samaritan volunteer, 30 years in adult social care, and about 15 as a therapist. A bit like Sade, I come at it from a starting point of, I suppose, being suicidal when I was 18 and wondering what that was like, and not really understanding what those feelings were. But interestingly for me, I suppose surprisingly, the person that most probably pulled me back from that was my father. And I say surprisingly because he was a person I wouldn't have assumed to be very present in my life. But it influenced me as an individual, in that I had my family and some close friends. And it wasn't about 3 years later, I joined and became a Samaritan at 21, and I was the youngest Samaritan in my branch in South East London. What interests me about this subject is suicide and depression. We don't like to talk about, we find a whole range of language and words to camouflage. And they cross with other taboos. Other taboos such as drug use, alcohol use, the way we are sexually, how we identify, how we want to be perceived by our families and our friends, and how we want to be successful and meet the expectations and pressures that we feel. Some of those pressures come from within, some of those come from our families and what I might argue our systems. We use a terrible phrase called systems. I try not to use very much jargon because I'm not very good with jargon. And but underneath all those feelings, people will give you hints. They'll use language which is comfortable for them, language which may camouflage a feeling. And I suppose as a therapist, my art sometimes, and my friends will joke that I'm very noisy and very chatty, so actually they do wonder when I'm doing therapy how I sit quietly and listen. But I can assure you I do try. As a therapist, I work with what's called humanistic theory, transactional analysis, person-centred, do some cognitive behavioural approaches, Oddly enough, my master's degree is in psychosexual therapy and issues around sexual and relationship issues. But all those approaches get muddled into one way of being with somebody. What I try to do is I try to start with the person. I start with what brings them to see me. Because actually I'm very lucky certainly as a therapist I'm very lucky. Certainly when I was a mental health social worker, you were in the middle of working with someone who was very unwell. As a therapist, people have made that first step, which is a really important first step, and actually is their start of their road to some recovery, because they made that step themselves. But I start with the person. I assess somebody, and I agree a contract, and I emotionally would never call it a contract with the clients that I see, but I have a contract which will say, if you feel really down, you text me. I will respond to you, and we will agree a time to have a conversation. At times when people are being very vulnerable and feeling very suicidal, I may see them more frequently, I may have phone contact with them in between visits. I'll work with them to see what works best for them and what works within their life, really. One client once said to me, "You are my best kept secret." And so using technology these days is great, because it means I can have contact with people without interfering in their day-to-day life, and without that going outside into them having to tell other people. But what I try to do in the therapy room, or what I try to do when I'm seeing people, is to help people have a language and a confidence to say some of the things that they feel and think. And so it's very important for me, whilst I would mostly say most of my clients wouldn't say I feel suicidal, it's important for me to say back to them, it seems to me like you're saying you're feeling suicidal. What do you mean by that? What are your thoughts? How does that feel? What have you been thinking about? Because it's about trying to help them move away from that sense of isolation with those feelings. I work with people's systems or their lives, and we all have a system. I have a system which is born and brought up in London. I have a range of sort of familiarities, and there are things about my life which make me vulnerable because of some of my history, our underlying issues, about where we come from and about what makes us vulnerable. You'll always, I'm sure if you think about children, you'll see that some children are slightly more robust than others, some are slightly more vulnerable than others, some are slightly more sensitive. We develop as children, my child development days are long behind me, but we mostly formed quite a lot of our initial beings as a person by the time we're 4 or 5. So actually, those underlying issues are there already. Maintaining issues. What maintains our depression? What maintains our suicidal feelings? And they can be a range of things. It can be our lifestyle, it can be the continual alcohol use, it can be being in an unhappy relationship, it can be being in a conflicted environment. Any of those things. I also look for triggers. Sade talked about alcohol. If someone's drinking a lot and using illicit drugs, most people do addictive behaviours, normally do 2. Rarely do they do 1 addictive behaviour. So if you're using drugs, and more these days with younger men, you're finding a range of sexual addictive behaviours in there, and there's a need to talk about that, because that isn't what they want, it isn't what drives them, but it is sometimes the only outlet that they feel gives them some of the comfort and escapism from their feelings. So I also look obviously at what supports the person, because if we don't look at what supports the person, we can't try to help them find ways of building themselves up. What I would say about all of this is, as someone who's spoken to quite a number of people who have been suicidal, and certainly as a Samaritan volunteer speaking to people who were actually attempting it at that moment in time, I'd say I'm not an expert. The expert is the person with their feelings. I would mostly say I'm not that skilled. What I attempt to do is to develop a relationship of trust and to develop a relationship of openness so someone feels safe. which does mean that some people turn up to see me on the rare occasions and doesn't really like the look of me, which is absolutely fine. Because actually, the relationship, if you're going to see somebody as a counsellor or therapist, you have to feel really comfortable with them, because you're going to tell them some really personal things. And certainly as someone who's gone through therapy, you know, I was quite fussy about who I saw, because I didn't want the things I was going to say to be said to someone I didn't feel comfortable and felt some warmth to. And it's really important. So I would structure it in this way. This is how I work. I'd mostly say, if anybody knows me in Brent, you'll never spot that, because I'm much more sort of fluid, but that's how I write it up in my head. And from that, I will come out with a hierarchy of needs. So I'll start with what really needs to be addressed first with you. It's a way of managing these practical issues, which means, as I'm not terribly adverse to doing practical stuff, I'll set out with them, we'll find information about who they need to go to, we'll identify the best person or the best organisation that can support them to resolve those practical problems. If necessary, I'll do a referral letter, I'll talk to GPs, I even want to talk to someone's pastor. Because actually it's the only way to enable them to make that movement. And so for me, being a therapist is, you know, not always to someone who sits there and nods. And I don't, well, I do nod quite a lot, but I don't just sit there and nod, I can assure you. I tried to set out, just give you an understanding of John. John actually was a Nigerian man in early 30s, stage 2, single, very suicidal, long-term depression, going back mostly into his teens. John was isolated at school, born in London, but sent back when his parents split, through an unusual and difficult relationship. And he went back to be schooled at boarding school back in Nigeria, maybe about 7 or 8. And he really struggles with being brought up in London and then going back to a very different society, a different range of norms. And never felt it quite fits in. Quite a lot of abuse in the school, I would actually say more emotional and physical. He was a very slight man, which I think maybe added to some people's taking advantage of it. He certainly lacked close friends. I could only identify one close friend when I first worked with him. He had issues around the change of home, never really wasn't sure whether Nigeria or London was his home. And also didn't have a settled home in London anyway. That sense of belonging, his parents' separation, there were lots of unspoken issues in the family, and it felt very familiar to me to come from a very Catholic working class family, but a whole range of unspoken things going on. So we bonded most about his family actually, because whilst on the face of it we were quite different people, actually there was a real commonality in the roles of men, the roles of women.